All right, well, thank you for having me. Please feel free to interrupt me at any time and ask questions or answer any questions that I kind of pose to the audience. The first thing I just want to say is I just want to thank Sunny and Ari, for putting these kind of meetings together. There's a lot of good people working on prostate embolization research, and that most recent study from Northwestern, from Riyadh Salem, was really good. It's very hard for us to get published in the urology literature right now. We've submitted multiple studies that have been rejected. You can tell in the reviewers' comments that they're pretty biased and they don't want them published. So the high quality studies that we're getting in there are very beneficial. But Ari and Sunny may not have been the kind of pioneers internationally for doing prostate embolization, but they're certainly becoming pioneers in the United States and doing these educational seminars and spreading the word and getting people out there doing prostate embolization. So a big thank you to them. This is just Terumo's exclaimer saying that all this is my data, and this represents my views and not theirs, and I'm only talking about on-label stuff. So prostate embolization, traditionally performed, and I say traditionally, it hasn't even been performed that long, but mostly via femoral access. I think femoral access is great. I also think radial access is great. I think you have to really choose your patients carefully. I'll give kind of a few hints throughout this talk as terms of what equipment I use, even if it's not a radial equipment. I actually think it's pretty easy to go up through a femoral access, and I use a RUT catheter to get into the internal iliacs and not into the prostate arteries. But I usually find that I can do almost anything with a RUT catheter from the femoral. But there are advantages to going radial. You're dealing with a lot of older men who have very tortuous arteries. This isn't like a uterine fibroid population. Ari actually had put out a paper and gave some general criteria for kind of the anatomic considerations you want to consider for PAE. So you don't want to pick somebody who's too tall. My limit is probably about 5'10", and I'll be honest with you, 5'10" pushes it sometimes. I do all of my other work, my liver embolization, I do all of that radial, and I'll go up to 6 feet and they're fine. But a 110 centimeter catheter, reaches the celiac and SMA pretty okay even on those people. But you're really pushing it for prostate because as of right now, we're limited in the equipment that we have. Maybe in the future we might have longer microcatheters and it may help us out a lot. So the advantages to radial, which was reviewed yesterday, you get decreased radiation exposure to the operator, especially depending on how you position your patients. It's increased comfort for the patients. I do a lot of patients where they've had femoral access and then I go to radial access and they swear that they would never want to go to femoral access again if they didn't have to. A minimal bed rest after the procedure, and then they have fewer post-procedural restrictions. So as far as the radial equipment that I use, I don't, what I'll say is I don't try to sell somebody on any product. I mean, I think you should be comfortable with what you use. I don't say that I use Terumo products because Terumo's paying me to be here. I use Terumo products because I like Terumo products, and maybe that's why they have me here. What I start out with, I used to do a 6 French glide sheath slender, but then I switched to a 5. There is a little more room in between on the 6 French for flushing the catheter, and I thought that maybe that might decrease the risk of thrombosis because you're actually able to flush the catheter. I did move to a 5 French now. It seems to be a little bit better. I do use nitro, verapamil, and heparin. For nitro, I use 200 micrograms, verapamil 2.5 milligrams, and then 3,000 of heparin. Just like Ari said yesterday, I tend not to re-bolus somebody unless I'm actually a really, really long procedure, and then I may give them another couple thousand of heparin. Terumo has this 0.35-inch Baby J glide wire. Ari was saying yesterday how he uses a glide wire and then it tends to select out a lot of the vessels on the way up the arm. The nice thing about this baby J glide wire is it's a very tight J, and you can get it all the way down to the arch and it doesn't select out anything. So it's a pretty atraumatic wire. You also want to use a glide type wire. Going up with a non-glide might be a little difficult for various reasons, anatomic reasons. You need a 5 or a 4 French angled catheter, usually a vertebral type curve. That's about 120 to 140 centimeters in length. 140 centimeters is probably pushing it a little too much because you don't have a lot of room for your microcatheter if you're dealing with a 150 centimeter system. So I happen to like something that's about 130 centimeters. I'll show a few cases here that are 125, and that kind of barely did the job. As far as microcatheters and microwires, you need small size catheters. These are very small arteries. 2.8 French catheters are probably not going to cut it for most people unless they have gigantic prostates that look like, fibroid uteruses. So my go-to catheters are usually a 2.4 prograde, or if these are very small arteries, and I know going off the bat it's a small prostate, then a 2.0 French prograde alpha, which has only been available for now probably a couple of years. The other thing is, there was a poll yesterday. What's the best catheter for selecting prostate arteries? And I think 80% of people said prograde. Well, there's a reason for that, because the prograde's a really good catheter. But whatever you do use, just get used to it. Some people in here have a lot of experience with things and some people don't, but find something you like, you know how to use, and you know how to use it well, and that'll probably do more good than anything else. There was a little misconception yesterday, I think, with Charlie Nutting. He said that you couldn't use a double angle GT through the newer 2.0 prograde alpha. That used to be true. I think Ari had corrected that a little bit yesterday. They now make an 016 double angle GT, so you just have to make sure you use the 016 as opposed to the 018. The other thing is that it doesn't accept all 016 wires. Okay, so if you're going to use something like a Fathom wire, it's not going to fit through this catheter. And the reason is because these hydrophilic wires actually expand a bit when they get wet. The 016 Glide GT has pretty minimal expansion on that wire, and it's pretty uniform. The Fathom wire, which I use sometimes for certain things, it's a good wire. The problem is it does expand more than the Glide GT, and it'll get stuck in the microcatheter, so you really can't use that. You might be able to use it for like 30 seconds, and then after that it's pretty useless. I use a TR band radial compression device, and I work with the left arm out at 90 degrees. So I work like this, and I work behind a lead shield. There's a lot of, radial access has become very sexy lately, and there's a lot of people kind of pushing the envelope and doing different things. I don't do snuff box access. I think, especially for prostates, you're going to be pretty hindered doing snuff box access because you need all the room that you can work with. And if you start going more and more distal, you're just going to run out of catheter room. So the reason why I work like this, and I'll show you, is that here's one of my ex-residents. He's actually out at DADA right now doing a fellowship. And then one of our technologists and our physicist, Matt. And you can see how we position on the table so that this lead wall is right in front of the receptor and also the source. And you could theoretically do these cases without any lead on because you're just behind this lead wall. Here's kind of a more practical setup in the room. This is one of my old fellows. And you can see how he's working behind the lead shield. He's completely shielded from radiation. So when I mean decreased radiation exposure to the operator, I mean 0 radiation exposure to the operator. The other nice thing in this picture, as you can see, is that we got this big monitor right in front of you. So it's pretty convenient. You can see pretty well. You don't have to start magging up and doing digital zooms as much. Now, here's kind of the whole room setup that we have. This is my one of my technologists that wasn't very happy with me taking the picture. So, you know, fellow medical student, scrub tech, I think there's another medical student watching, and scrub nurse. Can anyone guess what procedure we were doing here? There's a hint in there somewhere. Anyone? Nope. Nope. Port? Yes, we're putting in radial ports now. No, this is a TheraSphere treatment because we got the mat on the floor for any spill. Anyway. One thing I want to talk about here. Okay, so this is important. And if you're starting out in a prostate practice, you're going to have a lot of trial and error. I didn't have any of these kind of conferences to work on. I had some SIR lectures that I would go through and study the anatomy and the lectures that they were giving. This setup works great for liver embolization. The problem here is you're working in obliquities most of the time for prostate embolization. So this lead wall is a big hindrance because you can't move your receptor. It'll start hitting the lead wall and you'll run out of room to work with. So you have to figure out another solution. So I didn't have any updated pictures, but this is all going to depend on your room setup. So I just happen to like to work this way because I can work right-handed, I can be behind a lead shield, and I can have the screen right in front of me. But for prostate, you're going to have to figure something else out. So you're going to either have to take this lead wall out and just use the plastic shield and then a skirt, and that's fine, or you're going to have to flip to the other side, work left-handed, and just work on the other side of the arm. But that also depends on if your monitors can swing to the other side. You can go right radial, which I don't love to do. I've, do it a few times, but I don't like to do it if I don't have to. So you got to kind of have to figure out your room setup because they're not all the same. I mean, this room doesn't work as well. My other room, which is a floor-mounted unit, works a little bit better for this. So kind of do a mock-up and just put put one of the techs or medical students or residents on the table and kind of see how things are going to fit. All right, so I'm going to go through a lot of cases because I think that's going to be kind of helpful, and it'll be a good review of things that we went over yesterday. So the first case is just kind of a illustration of why you need to choose your patients carefully. So this is a 68-year-old. He had a pre-procedure CTA. I do not routinely get imaging beforehand. I learned a trick from Ari Isaacson a while ago, and the pre-procedure CTAs are okay. They're not the best at being able to see the prostate arteries completely. I mean, there's some techniques that you can use to better opacify them. But in general, what I tend to do is I tend to put in a flush catheter in the distal aorta, and then I center it over the pelvis and I do a spin. And we'll go over a little bit of that later. But this was a pre-procedure CTA. I didn't think that things were terribly tortuous, and I thought this would be a good case for Radial. He's 5'10", which is right about probably my limit. So here's a ipsilateral oblique of the, actually it's a right common iliac artery, because I used a 5 French 125 centimeter vertebral catheter, and I was barely able to get to the internal iliac artery. So it's barely seated in there, and you can see on my injection there's a lot of overlap with the external iliac artery, which, I can kind of see where the prostate's coming from, but it's not the best view in the world. So then I put a microcatheter in, and I could really only do a selective injection of the internal with a microcatheter, which you get less visibility of the branches. I know a lot of these catheters are higher pressure catheters now, but I don't think it's a pressure issue. I think that if you inject whatever you're injecting, 3 for 9 through a 5 French catheter and 3 for 9 through a microcatheter, and you're still able to achieve your higher pressures, I think you still get crappier images with your microcatheter than you do a 5 French catheter. So I was able to get into the right prostate artery. I used a 2-4 150 centimeter prograde, and I did a successful embolization on this side. So moved over to the left side. Here's an ipsilateral oblique. Again, there's, I was barely able to reach into that internal iliac artery. You can see there's overlap of that external. I because it was a kind of a bear to get into this internal, or at least get the catheter seated, I did that contralateral oblique, because that opens up your internal and external iliac arteries, to kind of try to get it better seated. Wasn't really able to much, so I had to go in with a microcatheter and do the run through a micro. Imaging's okay, but we can do better. It's just less visibility where the branches are. Eventually was able to get into the left prostate artery. Does anyone see what the problem on this one is from yesterday? So rectal branch, okay? So a couple things. I mean, I probably had the length to do flow-directed embolization. I didn't have the catheter at the time. I'm marginally a proponent of flow-directed embolization. I don't do it routinely. But what I ended up trying to do is I wanted to coil off this branch, and I changed out for numerous longer catheters. At the time, I had up to a 160 centimeter neurocatheter, and I couldn't reach the rectal artery for coiling. So after a while, I just wanted to do a follow-up run because things just weren't looking right. And I either had, severe spasm, but I tried to treat with nitroglycerin, didn't do anything, maybe a possible dissection. So I quit, which I hate doing, and I brought the patient back a month later. So 1 month later, I went from femoral. I did a left common femoral access, and then you can see the left prostate artery is open. The left prostate artery here happens to be coming off what's a common trunk of the internal pudendal and inferior gluteal artery. Let me see if I can move. How do I actually move the mouse? Oh, there we go. So here's the prostate artery coming off here. Can you see that or no? Oh, okay. So I guess I don't. Oh, there it is. So there's the prostate artery going there. So again, kind of a review of things from yesterday. Here's your, umbilical superior vesical artery. Here's your obturator artery, which kind of ends in that fork. And here's your inferior gluteal artery, and here's your internal pudendal artery. So if you look somewhere between that internal pudendal and the superior vesicle, then you're going to find the prostate artery here. All right, so got in. Luckily, it was still open, and or recanalized, and but we have this persistence of rectal supply. I did an oblique here just to kind of better profile the prostate and rectal branches. And you've got a few options here. Again, you can select the prostate artery, you can embolize it and just hope you don't get reflux into the rectal. You can do flow-directed embolization, which again I didn't have available at the time, or you can coil the rectal artery and then go back into the prostate and embolize there. So I chose to go into the rectal artery and then embolize with two millimeters or detachable coils. And we'll get into this in a little bit as to maybe why. One of the reasons why I actually tend to favor coiling as opposed to flow-directed, I don't think there's any problem with flow-directed, but I do think that it minimizes the amount of embolic that you can get into the tumor or into the adenoma. When I'm coiling distally, I just feel a lot safer that I can push a lot more embolics into the prostate. Ari's B-dope certainly makes sense in that. It'll be interesting long-term to see if this actually makes a difference, but certainly flow-directed and then distal coiling and then coming back and doing a high-pressure embolization, it does make sense, and that's the same kind of reason why I tend to prefer coiling off these if I can. Well, anyway, so you come back here, you can see that after coiling off that rectal, we have a good prostate supply to the left. And this is kind of a good case where you can kind of see all the different things that point out the prostate artery. You can see this microvascular tortuosity. You can kind of see the vertical separation at midline that you're only opacifying the left side, and this nice parenchymal blush, which you're seeing in the central gland. All right, so this case number 2 is another radial case, and for this I used that 5 French glide sheath slender, and I used a 5 French 130 centimeter vertebral catheter. So what you can see here is you can see the prostate artery coming off here, and this is coming off of VP trunk. So you can see superior vesicle, you can see prostate, and then here you see your internal pudendal artery. There is some reflux into the external iliac artery. Just kind of, again, as a review of from yesterday, what's missing on this picture? Anyone? The obturator artery is missing, okay? So this is just very common, a lot more common than I ever thought it was, you know, and you can see the corona mortis here on both sides. So here's just a summary of, you know, where these prostate arteries come from and the variability. The hardest part of these procedures is actually just identifying the prostate artery, which is why I think these lectures are, I hope, helpful, because the more and more you see what normal things look like, the more and more you feel comfortable with what you're going to have to catheterize. Again, you know, Ari said yesterday he sat and studied, you know, the night before where these things were coming from. I just had to go through lectures and lectures and just say, okay, well, you know, these are all the branches. I'm seeing these 4 things going anterior, and it's going to be somewhere in between those. So here I got into the left prostate artery. Looks pretty good. Here's a cone beam CT showing that I'm opacifying the left side of the prostate and the central gland. But here's an important point, and I think this wasn't talked about so much yesterday, so I think it's important to stress. Partway through the injection, I saw something suspicious. So it wasn't there before, but it was this straight artery that was going too far down past the symphysis, and it did supply rectum. It kind of only opacified late, so we were able to finish the embolization. We just went pretty slow. I moved to slightly larger embolics. I don't have as much of a fear, like was said yesterday, about refluxing some beads into the middle rectal artery. The rectum's pretty tough, and it can take a little bit of non-target embolization. The penis, I prefer not to do that with. But what I do when I do my embolization is I make sure that I mag up, and I make sure that I turn my fluoro on a higher dose fluoro, because I want to see exactly what's going on. And I narrow my cones down, but I don't narrow my cones down as much as I do for, let's say, a liver embolization, because I want to see what's happening kind of outside that field. Here you saw partway through, I saw something suspicious, so I stopped and did a run, and I saw a rectal branch. There's other worse things that can happen too. So it's happened a few times, but partway through an injection, you'll start to see the superior hemorrhoidal artery, which is going to the IMA. And when you start to close off these small branches in the prostate, you're starting to open up these collaterals that go other places. So you really have to watch it under good fluoro to make sure that you're not going to continue embolizing something you don't want to be embolizing. All right, so we moved over to the other side, and you can see an oblique image here of the right internal iliac artery. This doesn't look like what a normal injection on the right side should look like. Does anyone know what the problem with this one is? So my fellow screwed up, and he did it in the wrong obliquity. This was actually a contralateral oblique of the right. But oddly enough, you can see the prostate artery origin pretty well on this obliquity. So, you know, again, it's great for splaying out anterior division, posterior division, not so great necessarily at showing you the prostate origin. So this actually worked out not bad, but we still repeated it in the ipsilateral oblique. So here you see, again, the prostate artery arising from the anterior pudendal artery. My catheter position here was okay, and I was able to get into the prostate artery with the 2-4 150 prograde. The problem comes with the next image, which is where when I was in the prostate artery, you see this pudendal artery collateral. So again, you're going to have to do a couple things, but for me, it was go down and coil this artery. But I didn't have a catheter that was long enough from Radial. So 150 centimeters was hubbed. My 5 French was hubbed. I didn't have enough room to go down and coil this. So I switched out to, at this point, a 170 rapid transit catheter. and I was able to get down into that branch, coil off the branch, and then come back and shoot the prostate. It looked okay. So the learning points from all this are that, radial access is great, and I'm a proponent of radial access. But for prostate embolization, you really have to choose your patients carefully. You have to choose their arm length, you have to choose their overall height, and I'm finding more and more that whenever I ask patients, how tall are you, they'll say, well, I'm 5'9", I used to be 6 feet, but I'm 5'9" now, and those are the patients that I'd probably go with the 6 feet, not 5'9", because their aorta is actually going to be pretty tortuous. So right now we have kind of limited catheter lengths unless you start to get, again, into neurocatheters, which are pretty expensive. You may not be able to do flow-directed embolization just because of catheter length, because even the longest catheters are 150 centimeters. And if you see something suspicious, repeat an angiogram. Stop your embolization and just do another run. Make sure you're not getting any more non-target embolization, because it's not the stuff that you see initially, but it's the stuff that you see partly after you're embolizing. The other thing that didn't mention yet, but if you're going to use certain balloon occlusion catheters, they will only fit through an 0.38-inch lumen. So it doesn't matter if you're using 4 or 5 French, but if you have an 0.35 compatible lumen, they're not going to fit through there. Okay, so just kind of know your equipment beforehand. What you'll end up doing, kind of starting off, and it takes probably about 25 to 40 cases to really just kind of get things down and get comfortable with stuff. You're going to go through a lot of trial and error, and then you're going to put catheters in, and then you're going to say, oh crap, that wasn't long enough, and my wire wasn't long enough, and hopefully these conferences help out a little bit with that. So here's a case which was actually a pretty frustrating embolization for me. So here's the cone beam CT, and like I said before, the best thing that I ever did was start off by just doing this cone beam CT with a flush catheter in the aorta. So I park it in the aorta, send over the pelvis. I use, as you saw, currently I have 2 rooms that I'll do these in, and they're both Phillips. And on the Phillips, I need a 13-second total. It's an 8-second spin, and then I add 5 seconds of contrast injection before I do the spin. So I do it at 4 milliliters per second. I do 4 for 52. I use full-strength contrast. I haven't tried half-strength contrast yet with this. I did try half-strength contrast in the liver, and it didn't turn out too well. So we just switched to full strength. And I've had no problems with this, and I haven't really had any problems with streak artifact either. So again, 5-second X-ray delay, 4 for 52, and it's a 8-second spin, so a total of 13 seconds. If you can do it from a propeller mode, you can cut that time down, but propeller mode on a prostate can be somewhat difficult because of height. So anyway, what you can see here is I've highlighted that. You'll have to just take my word for it that those both are the prostate arteries down there. Now, several slices cephalad, I didn't see a prostate artery opacified on the right. I did on the left, but not on the right. So again, incidentally, you see the corona mortis on this side. Left internal iliac artery, ipsilateral oblique. So again, reviewing things, you see umbilical, superior vesicle, prostate artery, which has that S-shaped curve, which was aptly for Schwartz. So I was kind of born to do these embolizations. And then you have your internal pudendal artery, and then your inferior gluteal artery. First I got into the VP trunk, but it went into the superior vesical artery. And you can see that it's supplying at least 2/3 and most of the bladder, which might kind of foretell us something. But you can see the reflux, because it was a common trunk with the prostate, you can see the reflux of the prostate artery. So I got into the prostate artery, did an injection. This was the early injection. This was kind of the late phase of the injection. And what you see is this pudendal collateral, which is preferentially filling on the right side. You see supply to the right prostate artery. And the catheter was kind of occlusive, and the branch, and this was a 2-4, I think, that I used, and it was kind of occlusive in the branch, so all the flow was still directed away from the prostate. So unfortunately, I can't really embolize from here because I'm going to get non-target embo. I don't care so much about the right prostate because it's probably occluded on the right anyway, but it's this internal pudendal collateral that I was concerned about. So I said, okay, well, maybe I can try to get into that collateral. So here's the cone beam CT just to kind of show you that I'm getting opacification of the left side of the prostate. I am getting some opacification of the right central gland on the far left picture. And then you can see that pudendal artery on the right. So here's a distal catheterization. It was kind of wedged in there. Did an injection. Saw the same thing, but I wanted to try to possibly still embolize that distal pudendal collateral. So I did a steep oblique to kind of splay out the way things were. And as you can see, there's no way I'm getting into that pudendal artery. I mean, it's just kind of through all these tiny parenchymal collaterals. So I pulled my catheter back. I did some injections by hand just to kind of see the flow dynamics and how things would be. I was able to get some embolic in on the left side without having any reflux. I don't recall, I don't think anything got into the right. I wasn't thrilled with it. I couldn't get all that much embolic in there anyway. Went over to the right side, and what you can see here is there's proximal occlusion of the internal pudendal artery, the supravesical artery, the prostate artery, and then on the late phase, you can see that there's segmental reconstitution of that internal pudendal from collaterals. So I did manage to get into that tiny collateral vessel just to inject it and see what was going on. And you can see these extensive tiny collaterals going to the bladder and maybe a little bit going to the prostate. And then you can see, this is a oblique view, and this is the AP view. You can see there's that segmental reconstitution of the internal pudendal on the right. Can't really do anything here because if you're going to embolize here, you're going to embolize, bladder and what's left of his, segmentally reconstituted internal pudendal artery. And as you could see, he's partially supplying that from the left side. So this is kind of one of those where flow-directed doesn't work because flow-directed redistributes your flow retrograde through these collaterals, but this main artery on the left is supplying those collaterals to go to the penis. So there's not much I could really do here for him. Nonetheless, what I told him is, I said, look, I don't think this is going to work very well. There's a small chance, but we'll kind of see how it works. I'll follow you up in a month. So his initial symptoms, he was IPSS scores of 25, which is severe, and his quality of life was terrible. 1 month follow-up, his IPSS was a 10, and his quality of life was a 2. So he was pretty happy. So it actually worked. I don't think it works all that often, but it can work with a unilateral embolization. Okay, so here's another case. Is a 77-year-old with BPH and LUTS. So let's go through his list. He's got chronic AFib on Coumadin. His EF is 19. He's got 3 MIs with ischemic heart disease. He's got an ICD, type 2 diabetes, hypercholesterolemia. He's got a right BKA from an old staph infection, and stage 3 chronic kidney disease. Guess where this referral came from? Yeah, urology. So on consult, his IPSS score wasn't terrible. An 8 isn't that bad. But he seemed to be, I think it was his frequency that was really bad. He just was very, very bothered by this, and his quality of life was really bad. And urology was willing to do a TURP had he not had all those comorbidities. So, maybe I shouldn't have gone forward with this, but we went forward with it. Here's a picture of the left prostate artery. I went in with a 2-4 prograde. The left half of the prostate, you can see there's some cross collaterals to the right side. And I was able to embolize here to stasis, but only a minimal amount reached the right side. So I wasn't really thrilled with how this embolization was going to go. I went to the right side, and what you can see here is I don't see a prostate artery. It's missing. There's no supply from elsewhere. His internal pudendal artery is not there. So that's occluded. So, you know, one of the things I would look for would be this distal IPA origin of the prostate artery, but it's not there. So this guy, okay, so we did a limited embolization, but did it work? Well, no. He came in, his initial IPSS was 8. He was unhappy. Then I made him worse. So he decided that, I think it was, I can't remember what the second one is, but anyway, he decided that he wasn't better, he was actually worse. So he went up to an 11. He was still unhappy. This guy was actually, he's a really easygoing guy. He's a nice guy. He was very bothered by his symptoms. He wanted to do something. So I brought up doing a repeat angiogram to kind of search for any other supply. Maybe there was something I missed. He insisted that we try. So I did a second attempt. The repeat angiogram still didn't show any additional supply on the right. I went on the left again and went into the prostate artery that I was in. There was just a much more rich network of collaterals supplying that right side now. You can also see arteries that are going down to the obturator on both sides. So was able to do more embolization here. But I think this is also a learning point, because this is a little bit earlier on, is this supply you would expect to be from a distal IPA, just the way it looks on the right side. But there wasn't an IPA. The internal pudendal was occluded on the right side. But I think what happened on this one is this ended up getting reconstituted from the obturator on the right. And I just think that we maybe didn't investigate or go out too far in the obturator to kind of see what those collaterals would be. So we were able to actually embolize him pretty well on this. And then 1 month after his second PAE, so his initial symptoms were 11, which was worse. And then 1 month after this, his IPSS went down to a 4, and he was pleased. He was very happy with it. Incidentally, this is also, I posted this guy on Twitter a while ago. You know, he had that BKA due to a staph infection. So he had a prosthetic limb, and he's the first guy that ever asked me to take his leg off in the middle of a procedure because it was bothering him. So he took his leg off and hung it up on the wall. Anyway, so that was a 1 month follow-up. He was pleased. At 4 months after his second PAE, he ended up having an IPSS at 2. So now we're talking about you know, a 9-point drop, and his quality of life, he was delighted, super happy. And I was actually ready to give up on him, but he actually convinced me to go in for a second round and try something else. All right, so I just want to see how I'm doing on time. Okay, so here's going to illustrate the utility of the ProGrate 2.0, or ProGrate Alpha. So here's a right internal iliac artery and ipsilateral oblique. What you can see here is, again, just kind of, you know, review, because the more you see, the better. So here is going to be your umbilical artery, superior vesical artery, obturator artery, internal pudendal artery, and somewhere in between that internal pudendal and the superior vesicle here is going to be your prostate artery. So that's coming off of your internal pudendal artery. So got into the prostate, you can see this pudendal collateral, okay? So we're going to have to go in and embolize that. This is actually a magged up image, so it looks pretty big, but this next picture you're going to see, you need a microcatheter that's going to get out there pretty far. And this 2.0 ProGrate is really nice because it's, first of all, it's as trackable as the other ProGrates are. And it's small size. It can accommodate to 500 microsphere particles. And it'll accommodate any 018 microcoils, including the hydrocoils. Again, you need an 016 wire, but now you can use the 016 GT. And it's a high pressure catheter, so you can actually get 750 PSI. This is interesting. So the coils that you use, does it actually matter? And I don't have the answer to this, but I just bring this up because here's an article in Press and JVIR. And they looked at midterm recanalization after embolization with hydrocoils and fibroid coils in an animal model. And what they showed was there were significantly reduced recanalization rates with hydrocoils as opposed to fibroid coils at 1 and 4 months. And what they did in this in an animal model, I forget if, I think it might have been a sheep, I don't remember, but they went into the renal artery and then they embolized. This one was with fibroid coils. So they took all 8 fibroid coils. The top left picture, A is pre-embolization, B is immediately post-embolization, so you can see there's occlusion. They did a 1-week angiogram on the bottom left, which showed persistent occlusion, but then at 1 month, they showed that the renal artery was pretty much completely recanalized. So then they did sections of these arteries, and they looked, and what you can see here is these black, let me get in here, these black things here, those are the fibroid coils, okay? And these asterisks in this big area right here, that's all thrombus that was formed. And then these little spaces here are areas that were recanalized in the vessel. And what you see here on the hydrocoil is these black spots are the actual metal coil, but the white is all the hydrogel material that expanded within the vessel. And this asterisk, you can see there's far less, you can see there's far less thrombus formation within the vessel, and there's smaller rates of recanalization, and the presumed cause was that the recanalization was due to these areas that had thrombus formation and weren't actually packed with plugs.
Quick question. So if you see that vessel that you want to catheterize, I assume you had a 2.4 French catheter there, and then you exchange. How are you now transitioning to the ProGrade Alpha? It's not your number one choice.
No, I actually do sometimes go with the ProGrade Alpha. What I kind of do is,
That example you just showed, what was that catheter? And then it was very small. So then do you exchange over a wire, give up your access? What do you do?
this one was, I had a 2.0 to begin with. Oops.
So that's a 2.0 there?
This is a 2.0.
That's a 2.0, but the image before where you see that branch that you want to embolize, is that a 2.0?
Yes.
And so that's your catheter of choice now, the Alpha?
I often go with an Alpha, yeah. What I'll do is I'll kind of say how big their prostate is ahead of time, and I'll kind of decide which one I want to go with. More and more I've been using the Alpha just because I can get the same pressure injection, and I find it just as trackable as the 2.4. Anyway, here was the cross-section. Now, does it matter? I don't know. Does permanent occlusion matter? I think that's something that we're going to have to figure out in the future. And I think that's a question for resorbable embolics versus permanent embolics, and whether or not this permanent occlusion of your collateral vessels really matters. And I don't have the answer to that, but I thought this was interesting. So we got down, coiled the pudendal collateral, and was able to safely complete the embolization. So go to the other side, ipsilateral LAO, so you can see the prostate artery, which we got into, successfully embolized. I'm going to go through some of these a little quick. So the rate of injection, this just show you the rate of injection really matters when you're doing embolization. I tend to go into the prostate, I'll do like a 1 for 3, 1 for 4, but you can kind of see as many collaterals as you want. I mean, if you do a hard enough injection, you're going to open up these collaterals. So the image on the left, you can see that we've opacified a collateral, but when I go in and do a lighter injection or even a hand injection, I'm not opacifying that. So I'm actually okay with embolizing here as long as I don't see that start to open up during the embolization. So here's a case for a radial access. So I went femoral here. This is with a RUC or whatever they want to call it now, catheter. So you can see this ipsilateral oblique. So here you see superior vesicle, prostate artery here. This is obturator, internal pudendal. So got in, did a light injection, then a more forceful injection. You can kind of see things open up a little bit, but I'm not too concerned about that collateral because I didn't see it on light injection. Went over to the right side. This is a really difficult bifurcation. It was a very difficult origin of getting into the internal iliac artery. I tried a RUC, a Simmons 1, a SAS2, a regular glide wire, stiff glide wire. Finally, I just managed to get seated in there a SAS2 catheter, and the run is okay, and I can see the prostate artery. But then when I put my microcatheter in and started to try to select the prostate artery, that SAS2 just didn't give me a lot of pushability, and you can see how much it's deformed when I tried to get in. And I wasn't even in the prostate at that point. But eventually I managed to get into the prostate, and it looked okay. But honestly, on that case, I wish I would have gone radial. Here's an interesting finding. So this was a person who I was embolizing. They had a prostatectomy, and they had for prostate cancer. They had recurrence at the surgical bed with invasion of the bladder, and they had hematuria. So we actually did this for bleeding. So this isn't really a prostate. This is kind of a prostate mess that was invading the bladder here, but I got into this artery. Does anyone see this artery that's going down here? Does anyone know what that is? All right, here's another hint. All right, so it's a testicular artery. So we did a cone beam to kind of prove it, and that was a kind of just a bizarre one that I hadn't seen before.
Did you embolize his testicle?
I did, yeah. Yeah, it was pretty small, and I wasn't too concerned about it. I used it was for hematuria. I used little larger particles, and I wasn't too concerned about it. He didn't complain about his testicle afterwards. So, I think a lot of these cases are now just kind of standard find the prostate artery type cases, which if we're running out of time, I don't necessarily have to go through.
I wanted to just give you a little time for question and answers in case anyone
Yeah,
has
yeah.
a question about anything. Does anyone have a question for Scott?
You use standard particles to start with, and then what do you expect?
He asked what the standard particles are. What particles do you like to use? And then you change that mid-embolization.
Yeah, so I'm of the opinion that smaller is better. I have to convince my wife of that, but I go with like 100 to 300 micron embospheres, or 100 micron or 200 micron embospheres. Can't tell you what that is, but I tend to stick somewhere in between the 1 to 300 ranges. I pretty much do for almost everybody. Some of the hematuria cases, if it's a little dicey, I might go to 3 to 5. But I'll start with somewhere in those range, and I'll go up to 3 to 5 if I need to.
You know, a lot of what you were talking about with the length is, you know, you really need like 1-2 inches. If you thought of just come up higher on the radial axis, have anybody who does radials comment on that?
Yeah. I mean, occasionally I'll go up a little bit. Yeah, I mean, you know, I'll cheat it by, you know, maybe up to 5 centimeters or so. It just depends, yeah.
When you do that, do you ever find that you have more issues with hematomas in the forearm?
I haven't. You know, again, I don't do it all that often. That's one of the reasons why you may not want to do it, because at least in the distal forearm, you have a little bit of bone and stuff to help you out with hemostasis. You know, I'm not a radial zealot, okay? I like radial access, and I think it's great for the right patients. But I'm not one of those people that will go all out and do radial at all costs and bag their radial artery, even though it's tiny, and, you know, do digital access and angiography. I mean, it's just, I think...
Riyadh Salem digital access?
Yeah, I mean, Riyadh does it, but, you know, I mean, even like pedal access prostate embolizations. I mean, it's just, things are getting a little ridiculous, I think, with trying to push the envelope on things. I think if you have the right patient, it's okay, but I don't think you need to go overboard.
Any other questions for Scott? All right, well, Scott, thank you.
All right, thank you.